So, unfortunately, I have to present this case. This was a 46-year-old woman that I saw in August of 2013. She presented with a 3-month history of numbness and weakness in her right hand. And over the next 2 months, she developed similar symptoms in the left hand. There were no sensory symptoms or weakness in her legs. She had normal speech and swallowing, no double vision, and her balance was normal. Her past history was relatively unremarkable. She suffered from depression, had no previous viral illness, no diarrhoea, and she smoked about 10 cigarettes per day, rarely consumed alcohol, and she had no relevant family history. The examination showed normal cranial nerve examination. She had slight wasting of the right first dorsal interosseous. She had weakness in finger extension, minimally on both hands, and which was worse on the right than the left, and she had weakness of FPL and the small muscles of both hands, which was again worse on the right than the left. Her power proximally was normal and her legs were normal. She had slightly brisk reflexes, but within the normal range, and she had flexor plantars and no clonus. And the sensory examination was not consistent. She had variable reduction in light touch in both hands and a glove distribution, but it fluctuated, and I wasn't sure whether it was real or not. Okay. So we did some nerve conduction studies on her, and she had, as you can see, I've got a cursor. Comment. Let me ask someone to comment. I've got circles around it, but Neil, what can?
It seems as though the APB amplitudes are reduced, but with reserved distal latencies and conduction velocity. Similarly, the right ulnar ADM's down, and as is the FDI. I suppose left ulnar FDI is down a bit as well. So you have again with preservation of conduction. So you've got a median ulnar neuropathy bilaterally, or I guess it could be we don't have any sensories on that table, so it could be lower trunk or more proximal.
Okay, so the radial may be a little bit small at 4.5 radial to EIP. Yeah. And so this is basically just showing you the C-maps, but the right side was significantly smaller than the left, but they're both quite small for the median. And the ulnar was significantly smaller on the right than the left. And first DI, you can see the right is quite a deal smaller than the left. So at this point in time, we have low compound muscle action potentials and normal distal latencies, normal velocities, normal lower limb conduction studies. Steve, what do you think about that? We did a split hand index just while we were there. It was 3.2. Can you comment on that?
Well, I mean, in somebody with weakness of the hand, and what that tells you is that there's a proportional atrophy of the median and ulnar innervated intrinsic hand muscles, both of the first dorsal interosseous and the ADM. So that kind of would argue against the presence of a split hand, that would kind of support the presence of a split hand. So what that would tell you is that the lateral intrinsic hand muscles, that is the thenar eminence, the APB and the FDI, are disproportionately reduced when compared to the ADM. We used a cutoff value with Dr. in Parvathi's paper of 5.2 with a certain sensitivity and specificity, about 73% sensitive, about 80-odd% specific, to differentiate motor neuron disease from non-motor neuron disease neuromuscular disorders. But again, it is an index, and that number was a statistical number. Whilst this would indicate the presence of something like ALS, you really have to interpret it in the context of your other clinical findings and your neurophysiology.
Okay. So her sensories were completely normal. I won't go through the numbers, but basically the medians were 21, 21 both sides, and the ulnars were about 6. Lower limb sensories were also normal. And this is just giving you an idea that They're quite very well formed sensory potentials, there's no question about it. Median somatosensory potentials were also quite normal. So there's no evidence either in the peripheral nerve or in the proximal sensory conduction in the median nerve, even though her median CMAPs were reduced. There's no electrophysiological evidence of sensory involvement, albeit that she did complain of sensory symptoms. Motor evoked potentials were also performed and generally did not show proximal block. You can see the amplitude at the wrist for the ADM was 4.6, and at the cortex was 2.7, so there was no disparity there. On the left side, the wrist ADM was 9.7, at the cortex was 2.6, so that on a percentage basis, one could potentially argue that on the left side there was some conduction block proximally, although without a spinal stimulation you can't be sure what level it is, but theoretically there may have been some proximal block in the left ulnar nerve as the distal amplitude was quite normal. The lower limb conduction was symmetrical. That's the MEPs that you can see there. Any comments so far? No. You're thinking of
It is an increment.
Eden-Lambert syndrome?
Yeah.
No, I mean, I didn't. But her lower limb CMAPs were quite normal, which would make it unusual for an Eden-Lambert.
Well, it's not just a question. I mean, I think the history said she complained of weakness and numbness.
Yeah.
Did she actually complain of numbness, or was that just that subjective pinprick thing? Or was she only complaining of weakness, really?
Yeah, she said it was numb, but I...
But did you take that, that she...
Yeah, I took it with a grain of salt because...
So it's important because, when you're trying to interpret
Absolutely.
history,
It's very
if
important.
numbness is not there, then it makes it much more likely you're dealing with a motor disorder.
Yep.
Numbness is there, you're sort of worried,
Well, absolutely. That's why we did somatosensories.
No, but just clinically. Yeah.
Clinically, it's a subjective symptom. She said she was numb,
Okay.
and she had variable reduction with light touch up to the wrist.
Yeah.
But I couldn't demonstrate any objective sensory disturbance. But she did complain of numbness. Yeah. It wasn't just fleeting sort of pins and needles. Yeah. Okay, so the EMG showed neurogenic recruitment with some fibrillations in first dorsal interosseous and occasional fasciculations, abductor pollicis brevis on both sides and in left tibialis anterior, with some reduction in recruitment in all the hand muscles that were weak. So, oops, that's not what I want to do. So she had reduced units for the firing rate. So it was a fairly normal looking units. There were occasional polyphasics, but on the firing rate that she had, it was a neurogenic pattern of recruitment. Not much in the way of active denervation in most of the muscle samples. So the only muscle that showed active denervation was first DI, which was wasted. So any further comments? So this is a woman who says she's been weak over 3 months. She's got low amplitude CMAPs, preserved sensory conduction proximally and distally, neurogenic recruitment with minimal active denervation, although some fasciculations in a number of different muscles. She got motor neuron disease.
Come on pretty quickly.
Yeah.
3 months, one hand and the other pretty quickly. I mean, it fits it, but it's very quick.
Is that fast for motor neuron disease, Steve?
Well, I mean, it's not fast on motor, nothing's fast on motor neuron disease, but I think the EMG, the overwhelming sort of flavour that I get is that there's reduced recruitment in the setting of an absence of denervation, reinnervation changes and ongoing changes in fasciculation. So you kind of have to wonder whether there is a demyelinating process going on proximally or at some point along those nerves. So that's one of the things that you have to think about if you're just seeing a drop of units.
Okay. Judy, what do you think?
Sorry, checking my phone going off. Yeah, I mean, I agree with Steve. I mean, there's much more reduced recruitment than active denervation, but the low CMAPs, it looks like motor axonal loss, but I guess there could still be something going on very distally other than axonal loss.
Yep.
But it looks atypical for MND with that
Yep.
degree of little denervation.
Yep. Distal conduction block in CIDP, is that?
Yeah, I mean, distal conduction block could explain it, but
Yep.
the distal CMAPs are all down, so it would
Yep.
have to be very distal.
Yep.
It's less common.
Can you get that with CIDP with normal conduction velocities and no block further up?
Do you normally get it? No.
Can you get
Can
it?
you? Probably. I mean, presumably you can get distal conduction failure. I don't know that I want to necessarily
Yeah.
call it
Yeah,
conduction
conduction
block
failure.
in
Yeah,
the
yeah, sure.
traditional neurophysiological
Yeah, yeah.
sense of conduction block, but you can get distal conduction failure certainly
Yeah.
from, ion channel abnormalities.
Sean, yeah. Yep. Yep. So her MRI spine was normal, Sean. Yep. Yep. Okay. So any other tests that you want? So anti-ganglioside antibodies were all negative. And I thought no one said anything about cortical excitability studies. We did cortical excitability studies to consider the possibility that, is this motor neuron disease or is this not? Is it a low motor neuron mimic of motor neuron disease? Steve, you want to comment on those?
So the patient is green, is that right? Or the control?
Control is green.
Oh, so control is green. Where's the patient? Or
The patient.
somewhere in the MMN category.
Yeah.
Well, buried in there. So, well, what you can see, this is on the y-axis is your threshold.
This is ALS.
Okay, so we've got three groups. The red is ALS, the blue is non-ALS, and the green are healthy controls. And on the y-axis, you've got your threshold, which is the current required to produce a particular response. And on the x-axis, you have the time interval between your conditioning and test interval, which is called the inter-stimulus interval. Now, in normal controls, between 0 and 7 milliseconds, you get inhibition, which is indicated by that green graph, and that's thought to be mediated by GABAergic cortical circuits, but also other things modulate that. And then you can see MMN, that's sort of slightly less, and then you can see the ALS, which is sort of completely abnormal, whereby the SICI, or the short interval intracortical inhibition, is completely absent, and we take that as a biomarker of cortical hyperexcitability. So the difference, I guess, presumably the patient is blue, so
Yeah,
there,
that's the patient.
if we were to take the average between, say, 1 and 7 milliseconds, they would sort of fall into the normal range above the cutoff value of also, I think it's 5.2%. So based on these studies, the patient doesn't have motor neuron disease.
Okay, so we saw these studies. The patient continued to have weakness in both her hands. She started losing some muscle in APB as well, and the rest of her examination remained much the same. So we treated her on the basis of this as potentially being a demyelinating neuropathy with distal conduction failure, some sensory symptoms but no obvious sensory block, and gave her gamma globulin. And 6 months later, her CMAPs have come up quite significantly, and she's had return of her power. She's pretty much normal. She's still got a tiny bit of weakness in the left hand, but you can see the ulnar CMAPs come to 10.4, the median 7.7. So there's quite a marked improvement in her distal conduction, and her strength has improved and come back to normal. So We think that this was a demyelinating neuropathy, predominantly motor. It's a question of how you would, this is just showing the CMAP amplitudes. So the questions that came through my mind was, Steve, is this a pure motor mononeuropathy with distal conduction block, an unusual presentation of multifocal motor neuropathy, as you published some years ago? Or is it subacute AMAN? AMAN, if this was an acute phenomenon with a gastrointestinal illness prior to this, could this have been an AMAN, Matthew?
Well, I think anything's possible, but I would go with Steve's. I think the phenotype is more like what he'd written up there in that series from his Boston experience.
Okay. And the other possibility is pure motor CIDP. This is a well-described subset of CIDP. There's been a number of cases described in the literature. There's 6 cases described in neurology here by Kimura et al. The difference between those cases and this case is that they generally got symmetrical generalised weakness.
So when did you see it? 2013, is that what
Yeah,
you told us?
yeah.
So have you stopped the IVIG?
I'm stopping it, yeah.
But you haven't yet?
No.
I mean, that should answer, that should get rid of one of those options.
Yeah, yeah.
At least. I mean, the subacute AMAN shouldn't relapse.
Yeah,
The
absolutely.
other two still might though.
Yep.
With it-
She's coming off it now, yeah. So what about motor CIDP, Judy? Does it fit the bill, or is it, that's more typically...
I mean, I think the MMN thing's probably slightly more likely. There's no slowing anywhere else. There are no other features of CIDP. I mean, to just have only very terminal conduction block and no other findings is pretty atypical.
Also, you said her reflexes were normal
Normal.
or brisk,
Yeah.
as opposed to the
Yeah.
A reflex.
I mean, I've had
there
2
and
cases of
symmetrical.
pure motor CIDP, and they didn't look like this. They actually had more generalised, but they had slowed conduction velocities. And they did respond, and the interesting thing is that motor CIDP seems to respond quite well to gamma globulin.
So does pure sensory though. I mean,
Yeah.
the purer form, the limited forms all seem to respond better than the...
There's a group of patients published in 2002 by Katz and Baron and Amato. Not sure if that's the paper you're referring to, Steve. They called it MAM, multifocal axonal motor neuropathy. These are patients who look like multifocal motor neuropathy but don't have evidence of conduction block. I think that, this is Dominic's patients that he uses Intragam for. There's this controversy about patients who have weakness, who don't show conduction block, who've got neurogenic changes. I'm not sure in this group of patients whether they actually had active denervation, but whether they simply had neurogenic recruitment. But this is another subgroup, and how that fits into the picture, I'm not certain. Do you believe that that exists, Judy?
I believe that group splits too much and uses too many 3-letter acronyms, even 6-letter acronyms to describe various subgroups of inflammatory neuropathies. But
It is Mother's Day on Sunday.
Okay.
It was a highly selected group, comprised of a variety of different centres from memory, 8 patients or something like that.
Yeah.
They just cherry-picked all the best cases that
But fit it in. And they didn't respond all that well to gamma globulin. A lot of them didn't. And so you wonder, whether that sort of were really truly responsive to Intragam.
So Tom, I presume you called your lady CIDP?
I have. For the purposes of treatment, that's what I've called it, yeah. So I'll finish off with just to sort of emphasise the importance of using other techniques to differentiate sort of lower motor neurone syndromes, which can be treatable and demyelinating from motor neurone disease. And Steve and others published the paper on the split hand index. And more recently, Parvati has a publication in Lancet Neurology, and I thought that she should sort of give it a plug and explain to us her findings regarding the differentiation of MND from other lower motor neurone syndromes using threshold tracking.